volume into a patient. How much is in that bag? Yeah, close to 1,000, 1,200 mLs in that bag. So you empty that entire bag in there every breath, that's a lot of volume, right? Especially if they don't completely exhale, then we start having the whole issue with breath stacking and breath trapping. That increases your intrathoracic pressure, and then that really does kill your lungs. So that's why we changed the emphasis of our back valve mask ventilation to just enough to see the chest rise. You don't have to empty the whole thing. Talking about ventilation and perfusion matching, basically in a perfect world, these should always match, right? Ventilation and perfusion should be equal. There are some parts of our physiology where that's not always so. So if you think about the upper lobes of the lungs, your ventilation is always going to be greater than your perfusion. Why do you think that would be? That's where all your air is coming into, right? That's the very first place it meets when you take a breath in, is it meets the upper lobes of the lungs, or the upper structures. Not a whole lot of vasculature up there. Most of your pulmonary vasculature starts at the pulmonary arteries and then subsegmental branches downward through the lungs, not upwards into the upper lobes. Middle lobes are the middle sections of the lungs. Ventilation and perfusion should be relatively equal, because this is where the two kind of meet in the middle. Airflow and perfusion from your vasculature meets in the middle. Lower airway, your ventilation is actually going to be a little less than your perfusion because there's more blood available but a limited air supply, unless we do one. Positive pressure, or we pump them full of albuterol. As far as monitoring goes, several different methods you can use to monitor capnography. One of those is qualitative capnometry, and those are the old school colorimetric CO2 devices. We all know that those are very limited, right? So you've got that beautiful yellow or gold, or however you want to term it, is good. That's basically how we knew that we had positive carbon dioxide levels reading. How many breaths does it take on average to actually turn that litmus paper? About 6 breaths, yeah, for you to get it changed. Quantitative capnometry?
It was tanner's trouble, and you could barely differentiate between yellow and tan sometimes.
Yeah, exactly, especially when you're colorblind. Quantitative capnometry, device that provides value. So it's going to give you a number, and it might let you see a little bit of a waveform, but not much of anything that's really tangible. And then quantitative capnography is the actual waveform, what we now use as the standard of care. So your colorimetric devices, you had litmus paper that was basically purple. It changed over to yellow if it detected the presence of carbon dioxide as you were given these ventilations. If that patient vomited up their breakfast, which we know in an EMS world happens quite often on codes, then that altered that paper due to that acid content in the stomach, and then you were kind of up the creek. You had no way to actually confirm or deny anything. How many of you knew that the alphabetical sections of the device actually correlated with an end-tidal CO2? I did not. That was something I learned that was new to me when I put this lecture together. So basically, section A over here on the far right, when you're giving your first few breaths, you see that it eventually starts moving from right to left across the device as far as the color change occurring. If your color change starts over at A, it's roughly 4 millimeters or less. Once B highlights, it's 4 to 15 millimeters. And then once the entire thing is lit up yellow, roughly 15 to 38 millimeters of mercury is your average CO2 reading at those points with the color device. This is an example of quantitative capnometry, so it provides a numerical value using infrared spectroscopy. This is also an example of mainstream capnography monitoring. This is the EMA device, which is marketed and sold by Massimo. Sometimes the fire departments around might be using them, but it's not something that we see widespread in practice anymore. This was kind of one of the first devices that hit the market when capnography came out back in mid to late 2000s, or early 2010s. You guys remember which case made capnography mandatory in the state of North Carolina? Drew. Yep, do it for Drew, so Drew Hughes. Anybody in here not familiar with Drew's case? So Drew Hughes lived down on the coast of North Carolina. He was involved in a skateboarding accident. He fell off skateboard, hit his head. Basically displayed concussive-like symptoms. Have any of you guys in here been through the EMS program in Western Carolina? So at Western Carolina, one of the things they have us do is a medical legal class where we actually discuss this case. And basically it's kind of an opinion piece, but they want you to do the research and determine how many things went wrong throughout this case that could have been prevented, okay? So looking at this kid presented to the ER in New Bern with a GCS of 15. He was neurologically intact, no deficits at all. He was fighting them, basically being his normal self. They took him to CT. The CT was negative, non-conclusive. So they brought him back to the ED. They felt like, given the circumstances, he still needed to be transported to a level 1 trauma center for further evaluation. All right? So they go to put him in the truck, but before they do that, they decide that based off the fact he has a head injury, he needs to be intubated. So they electively took his airway. At the time that they electively took his airway, that was mistake number 1. Should you ever electively take an airway? No. So this is kind of my Sermon on the Mount from the past couple of times that I've done this class with your groups. You guys don't RSI here, right? I never RSI'd where I came from. Doing drug-assisted intubation is something that you have to have a healthy fear of. For years, we've been taught the indications of intubation, right? It's real easy to talk about the reasons why we did it. It's delineated on paper. You can recite it verbatim from a protocol book, right? The more important piece of that puzzle is reciting the reasons of why you had no choice but to take that airway. Why did you get backed into the corner? It's much easier to defend your decision and defend yourself for taking that airway if you can describe that. And that's actually how we practice at Med-Center Air. So I came from a service who never RSI'd. I had to get very good at using a bag valve mask. In the 4 years that I've been at Med-Center Air, how many patients do you think I've electively tubed, or tubed period, as far as RSI is concerned? I've tubed 4, 1 a year, basically, for the last 4 years. It's very rare that it truly needs to be done. And there are other alternative means out there. If you guys have one of your King Airways in place when we arrive on scene and you show me a good pulse oximetry reading and a good end tidal, guess what we're not doing? We're not exchanging that King Airway for an ET tube. We're going to leave it in place. There's absolutely no reason to. You've got an airway. Why do I need to go muck it up? Right? Don't, if it ain't broke, don't fix it. In Drew's case, so kind of finishing that up, he was intubated electively. They put him in the back of a truck with a crew that was not the normal critical care transport crew. They sent hospital staff along for the ride. I believe it was an RT and a nurse that went. Essentially, during the transport, he self-extubated. The crew recognized that, and instead of actually going through a drug-assisted intubation procedure, they elected to push a paralytic only. So they gave a paralytic, and after that point in time that they gave the paralytic, they proceeded to place the tube. They had no way of confirming it, and he actually had an esophageal intubation. He subsequently died from a noxic brain injury due to an improperly placed ET. After all of that came to light, the case was reviewed by the North Carolina Office of EMS. There was a lot of litigation involved. That was when the state of North Carolina said, okay, this is no longer negotiable. You will put these patients on the entitled CO2 monitoring. There is no ifs, ands, buts about it, okay? That's how we've gotten to where we are today with use of capnography. Quantitative capnography, this is your waveform as we know it today. Infrared spectroscopy, basically the lights determine your value and displays it as a waveform on your monitor. Your waveform gives a visual representation of your underlying pathophysiology based off of exhalation. So you can actually see a lot of things in your waveform that are going to tell you what's happening deep down in those lungs and how you need to actually intervene to fix it. Normal values, remember that your entitled CO2 will always be less than the PA CO2 that you would normally see on a blood gas, okay? So usually by a value of 3 to 5. Entitled can never be higher than your PA CO2. Your normal entitled values, we all know this, is 35 to 45, right? In a perfect world. What patient population might alter this? Your COPDers and your asthmatics are going to alter this to the high side. What about the low side? Do you guys have any LVADs over here?
One.
Yeah, so if you encounter an LVAD in the field, their entitled may actually be low. Usually around that 25, 28 mark. Abnormal values, so if the entitled is greater than 45, probably going to be a respiratory acidosis due to the hypercapnia. What do the COPD patients do to compensate for this? They're usually tachypnic, right? They're always a little mildly tachypnic. Entitled CO2 of 35 or less may indicate respiratory alkalosis. Hypocapnia metabolic acidosis or decreased perfusion. So along those same lines, those end titles of 25 in the sepsis patient, that was one of the things that came out of the surviving sepsis guidelines when sepsis first became a real issue for the healthcare systems, was looking at how can pre-hospital providers identify sepsis in the field, right? So what methods did they give us?
Temperature, heart rate, blood glucose, and
exactly, so the Sears criteria plus capnography. So we were using Sears criteria, and then if we had an end-tidal CO2 of 25 or less, that correlated in most studies to a lactic acid level of 4 or greater, which satisfied the qualification to actually diagnose sepsis and start those treatment bundles early. The treatment bundle varied depending upon where you worked. In our system, we didn't carry antibiotics, but what we actually did was we implemented blood draws. Back in the day, we didn't do blood draws because what happened when you brought in blood from the field that you sat on the counter and told them to send the lab? They threw it away, right? The hospital was actually who came to me as a training officer and said, can you make them draw blood? They wanted it done. They were like, because A, it gets things kicked off a lot quicker, we get the lab values back faster, and we can actually work on patient outcomes by addressing it via this needs. So we started doing blood draws for sepsis. It ended up going so well that we increased the blood draws from sepsis to all of our cardiac, respiratory, and stroke patients. So blood draws are now a standard piece of the puzzle in our protocols.
It used to be we did a routine so they could get a baseline.
Yeah.
And they would just blow them away when you walked in the door.
Yeah.
There's a question about that. So the last class I took concepts is said that they no longer believe that it correlates to a lactic acid of 4.
Yeah, so there's some research out there now that kind of says maybe that's not necessarily the case. They're still kind of weeding through it to figure out what their final result is going to be. But there's also other factors that go into that that could be the reason that that's altered too, right? Could it be based off the interventions we're doing in the field? You know, are they getting a true representation of the lactic acid levels at the time of impact? They're drawing 9 times out of 10 in the hospital after we've already initiated our interventions. So, yeah, so drawing blood cultures in the field, drawing that initial set of labs can help you get a better baseline picture of whether or not those results are actually true. So those are some things that are out there right now. Abnormal values for blood gases. I'm not going to bore you with blood gas speak, other than knowing that typically with acidosis, your pH is low. And then if your CO2 is high, we know it's respiratory. If your pH is low and your bicarb is low, we know it's metabolic. Same thing on the alkalosis side. If your pH is high and your CO2 is high, then you're probably going to be looking at a compensated alkalosis because your bicarb should also be high as well. And then if your CO2 is low, then we have to go back and look at our bicarb again and see what it is. Hypocapnia, that end tidal less than 35, causes hyperventilation. That's an easy blanket statement, right? Well, let's get into the weeds of the hyperventilation piece of this. What are some causes of hyperventilation?
Anxiety attack.
Anxiety attack. I'm glad you said that first thing because this was one of my pet peeves at home in Watauga County. So in the great state of Boone, as we call it, what big booming monstrosity lives off River Street in downtown Boone? You guys frequent Boone? Appalachian State University.
Oh.
It's a college town. I used to purposefully not sign up for base 1 on Thursday nights because Thursday night's Thursday, and base 1 is the college truck. So try to avoid college campus if at all possible.
UNC shop.
Exactly, same
Halloween
thing.
is the best time for people watching.
You're not wrong there. You're not wrong there. All right.
Actually, the worst one was Davidson.
Yeah. So looking specifically at the hyperventilation piece of the anxiety attack, what's the issue with that on a campus like that? It's real easy for us to walk in there and find that hyperventilating girl and just write her off as an asthma attack, right? Or an anxiety attack, I should say.
Well, it's easy, but it shouldn't be because that's a primary for a PE, secondary for birth control.
Bingo! Bingo! You're the first one to actually get it straight out of the gate. Every one of those girls is on birth control. That is a risk factor for pulmonary embolism. So how can you sit there and tell me this is an anxiety attack versus a PE? Can you rule one of the two out?
Well, to tell you that there's a history. Anxiety and the boyfriend just broke up with him half an hour ago.
She's taking the words out of my mouth. She's taking the words out of my mouth. Yes, yeah. If they look at you and say, my boyfriend just broke up with me, then that's an issue. My general response was always, honey, you're on a campus of 50,000 people. There's plenty more fish to see. Go find them. You have bigger fish to fry than sitting in the back of my truck crying. Okay? Or there was another one of mine that was a favorite. It was an anxiety attack / overdose. So when I asked her what she overdosed on, she said ibuprofen. I said, well, how much did you take? Oh, I took 4 tablets. And I said, congratulations, you won't have a headache today. It was 800 milligrams. That's all she took. It's amazing how that works. So, not always anxiety, could be a PE. What are some other causes of hyperventilation? Sepsis. Yep, very well. Any sort of metabolic acidosis can cause hyperventilation. What's another good one out there on the metabolic acidosis spectrum? It's one of my favorite things in the world to treat, even in the critical care world.
Hyperglycemia.
Hyperglycemia, so our diabetic ketoacidosis patients, they're going to be hyperventilating. What's cardinal sin number 1 with a DKA patient?
Not recommending it.
So, that, yeah, we can say that's number 1, but even higher on the totem pole than that.
Giving glucose?
No?
You shouldn't be doing that.
No? Intubating a DKA patient's a death sentence. Why? What typically happens? I see this all the time at work. You would think it wouldn't happen, but I see this all the time in the line.
She's knocking out one of their complex treatments.
Yes, you are killing their ability to compensate.
They try to wean their respirations down.
Yeah, so nothing makes me angrier than going in and hearing this patient's in DKA, but they were tiring me out, so we intubated them. And we currently have them on 18/450 and a peak of 8 with a 40% FiO2 on the ventilator. I'm like, okay, time out. What's their blood gas? Oh, their pH is still 6.9. It hasn't budged. Well, it's not going to. Newsflash. What were they breathing before you tubed them? Oh, like 35 times a minute. Then they need to be breathing 35 times a minute after you tube them, because that's the only way you're going to compensate for them. So you end up having to go back behind them and do a little cleanup work, because if you leave that respiratory rate down, they're not compensating at all anymore, and you're actively killing them with the one thing that's supposed to be saving. So we always tell people, don't intubate a DKA unless you just have to. Or if you're going to intubate it, at least know what you need to do with the next settings afterwards, and for the love of God, paralyze the patient. So that's another example of that. Hypoperfusion plays a role in this as well. We know this because we use this in cardiac arrest, right? We'll talk about that a little more in a little bit. But that decrease in blood flow means there's not a whole lot of gas exchange occurring at the surface of those blood vessels, right? And then hypothermia, it's the same principle as hyperperfusion. Hypercapnia, you've got that end-tidal CO2 reading that's greater than 45, causes obviously ventilatory failure. Again, a very good blanket statement. Talk to me about ventilatory failure. What are some magic numbers that we can put out there that we can monitor in the field to determine that this patient's in true, bona fide respiratory failure? Yeah, so you can look at your clinical context and your patient assessment, they're having respiratory stress. But as far as diagnostic, actual numerical values go, what are the 2 magic numbers?
GCS.
So you could look at GCS. I'm thinking specifically to oxygenation and ventilation.
Respiratory rate?
You could look at respiratory rate, but even more specific than that. Pulse oximetry and an end-tidal CO2. If their pulse ox is less than 90 and their end-tidal CO2 is greater than 50, they've met the diagnostic definition of respiratory failure. So at that point, maybe we need to be a little more aggressive with our interventions. Now,
Can you repeat those values again?
yeah, pulse oximetry less than 90 and an end-tidal greater than 50. Talking about CO2 retention, that's another piece of this as well. We hit on it. Our COPDers are chronic retainers, right? They might live with a value of 78. It's not perfect, but it works for them, right? How do they compensate? How do they help keep themselves balanced in that state? They kick their respiratory rate, right? They may be a little tachypnic at baseline. Now, if you walk in there and you find one of them breathing at 18 times a minute, knowing that their compensatory rate's probably 22, and they've got all of these intercostal muscle retractions and they just look like crap, does that raise your suspicion that this is about to go south real quick? Yep, they are already in failure, and we need to be very, very aggressive with what we're doing. We need to hit them with all of the things, the bronchodilators, the steroids, the MAG, the CPAP. Hit them with all of it, or whatever you have in your protocol. And then they're probably going to be acidotic. So stabilizing and correcting those values, how are we going to do it? Adjusting minute ventilation. That is your primary target, adjusting the minute ventilation as a whole. So altering rate, altering Tylenol rate. Again, how do we do those things in the pre-hospital setting without the tools of having a ventilator or a lot of the things that the hospital has? This is where all of our medications and our CPAP and all of our non-invasive stuff come into play, right? So CPAP, bronchodilation, your steroids, all of the things. All right, you guys still okay, or do you need to take a break? Take a break? All right, let's take 10 minutes, and then we'll go from there.